if the anatomy is hard with the wand and the way the leaflets are deployed, do you ever have to spin it or turn it? Like, let's say now you're on the hard side and maybe you can't quite see, but your feedback's like, I'm not touching anything. So do you ever have to kind of turn or spin or rotate or, I don't know, tell us some tips and tricks when it gets hard?
Yeah, all the above. The wand is nice. It is malleable. So you can bend it to, if you're on the patient's left side, you're going to bend it to the right. So it curves into that posterior nasal nerve area a little bit better. And then it is just these fine little movements with your wrist. So you're twisting it a little bit. You're maybe pushing a little bit lateral. And remember, I had mentioned that it takes half a second now for the device to detect the tissue apposition. Before it was 6 seconds. So in Gen 2, you would twist it and you'd have to literally wait 6 seconds for it to go through its algorithm to check all of those leaflets. And it felt like forever. And so now with Gen 3, if you make a little adjustment within a second, you're going to get your answer. If that doesn't work, you adjust it a little bit more by pushing up, pushing lateral, twisting your hand, anything you can do to change the location a bit.
And so each side, if we're just talking about the posterior nasal nerve, each side is like, a minute, essentially.
That's about right. Yeah. Sometimes.
So very fast.
Sometimes a little bit more, but I would say probably on average, about a minute of energy, but to do it and to move it around and get good apposition, probably 2 to 3 minutes tops.
Yeah. Yeah. Which is, I think it's still pretty quick.
Yes. Yeah, it's quick. And again, there's times where it's 30 seconds that you got great tissue apposition, low impedance, and boom, you do one, you do another one, and then you do a third in less than a minute and you're done. And you're done knowing that you delivered the proper amount of energy. That's what makes me feel good about this particular device.
Okay. And then when you do it in the OR, I assume it's the same. You just get to skip your anesthesia protocol.
Yeah. And if there are some occasions where, let's say someone just has maxillary anterior ethmoid sinus disease and I'm just opening up the front sinuses, not a full house, but they really have classic postnasal drainage and they're over 60 years old. They've tried ipratropium and it helps. I will do it sometimes with sinus surgery as well. If I'm going to do that, then I'll do the PNN ablation first, just because I don't want to have blood and mucus tracking back there. And I think it's just an easier thing to do before you get a bloody field.
Yeah, just kind of cleaner. The posterior nasal drainage symptom is interesting to me. And I don't know, has your practice evolved? When this came about, I feel like the patient I thought of was like the little old person with the tissue who always had kind of like anterior rhinorrhea. But more and more as we talk about it, postnasal drainage comes up. And so, I don't know, just your thoughts.
Yeah, it's a very common symptom. I think that's what we're finding. And yeah, you're classic, the older lady with Kleenex tucked up her sleeve. That's the classic, but it's very, very common in guys too. And it can be young ladies, young men as well. It's just one of those annoying symptoms. The other thing it overlaps with, which is more challenging, is chronic cough. Sometimes I'll have a pulmonologist or allergist send a patient to me with chronic cough who they say, has some postnasal drainage. Can you consider that procedure? And then that's a whole discussion about how many things can cause chronic cough. And again, I'll do a trial of ipratropium spray. If it helps, then, I say, well, we can try it. But it makes me a little concerned if chronic cough is the chief complaint with a little postnasal drainage on the side.
Are you still doing, let's say you have a patient who has kind of been through the ringer as far as workup goes for chronic cough and, they don't respond to ipratropium spray, but they're like, hey, can we please try this thing because I've tried everything. Like, what's your talk track?
I would only do it if they say, I constantly feel stuff dripping down the back of my nose. I know there's stuff draining down the back of my nose going into my throat that's causing me to cough, and then I will have done a flexible laryngoscopy just to make sure there's nothing down there. And then I'd consider it. Sometimes these are desperate people, and by all means, you don't want to take advantage of a desperate person. Our job is to rule out bad stuff and then treat them with, something conservative if we can. And if we think this is going to help, do it. If not, then walk away.